Dr. Vinu Moses, interventional radiologist and CMC's visionary in IT. Ms. Anaita Singh from Bill and Melinda Gates Foundation is also here. She will join us on the panel. Prior to her joining the Bill and Melinda Gates Foundation, she's worked with multiple organizations, including Dimagi. Thank you, Anaita, for joining us. And Ms. Anisha is also here. She's just given us a talk just now. Thank you, Anisha, for that wonderful talk. We look forward to having some more conversation with you. Dr. Uma is also here. Dr. Uma, thank you for being with us and helping us with studying our telemedicine unit as well, and for all the insight that you provided us today. Welcome to the panelists, and we look forward to your questions as well. If you could just WhatsApp it back to this number. If we have the time, we will take those questions as well. Today has been a really wonderful day for me because I learned a lot of things, starting from what AI is, very clearly presented by Andre this morning, and I want to start with that thought. He said we must start with data collection now, and we should already be collecting data because you will then reach an upward spiral when it becomes useful. So on that question about that, and then we learned about how health data should be collected, and it was very exciting in the morning listening to that. And then in the afternoon, we also heard about the challenges that we have and the considerations that we must place. So I think the initial part of this discussion, I'd just like to open it up to all the members of this panel. I'm getting these mics back in so that I can get some of your views on, if we can have your views on just this whole morning's experience, and I'll take it from across the board. Vinu, do you want to start off just about what we've learned today, and what do you think are our key takeaways from this day's discussions?
So it was a very interesting session today morning, and I think all of us have learned a lot. I think some of the key points that I could probably highlight is one, that none of us have complete data sets. All of us have incomplete data sets, but that should not hinder us from starting our journey on machine learning or AI. We need to start with what we have. We could use tools to clean up some of this data. We could formulate strategies to collect better data in the future, and that should not prevent us from continuing this journey. The other was a lot of the legal stuff that I learned, and that was very interesting, and that was an eye-opener.
Sanjay.
Thank you. I think I've taken about 30 pages of notes. I don't think I'll go through all of them. But I think just coming to the couple of things that I sort of might know a bit about, and I think especially because I came here yesterday to talk to some of the CMC colleagues to try and rev them up to doing similar things. And I think one of the challenges is kind of getting the research mindset, especially amongst the clinical colleagues. I think given the Indian context, you obviously completely rushed into doing your clinical work, and there's not enough headspace to be actually thinking about research questions. So I think somehow creating mechanisms where people who are on the front line of healthcare are actually, when they're looking at a patient, looking at a problem, thinking, could I use data or AI if need be to solve that problem? That will make my life for clinical decision making easier next time around. So I think that point was well made on starting to get on going with it as a way of learning, especially for the clinicians. I think the other point is about data quality that you mentioned. So I think Raghu made a good point about being it fit for purpose. To give you a slightly concrete example, I run a cohort study in Telangana where every few years we collect huge amounts of digital and non-digital health data to study the health impact over years. And this time when we were collecting data, one of the questions was that we wanted to take lots of images of all sorts, try to predict things from those. And one of those was body image to predict somebody's obesity, if you like. And my team were asking me the question of, we read all these papers, and people are putting people in these kind of suits to iron out all the noise, so we can get a very clean image and see how well we can predict. And my obvious question, taking the cue from Raghu, was, well, what are you going to use it for? If you want to have the ASHA worker going door to door, taking a picture to predict somebody's obesity or diabetes, you want all the noise in there. You want to take a just standard free living picture without any of the fancy stuff, no strong background, which you're not going to do at home. And then trying to predict from that and see if there's any merit. Otherwise, that idea is a non-starter to begin with. So I'm going to stop now and let other people say what they want.
I think what you mentioned is very important because Raghu has the similar experience with Wadhwani AI and measuring neonatal weights, and what you did in the lab was very different from what you would do in the community. So that's an excellent point. So we'll come back to again how research is so important for how we get data. But Anaita, first to you from your previous experience as well as what the Bill and Melinda Gates Foundation is looking in the space.
Thank you. And it's been a pleasure to be here. I was just thinking that I took a lot of notes as well. I should have just used ChatGPT and summarized them. But I was taking it in my notebook, so old habits. But very quickly, I think one of the speakers had said this line around solutions we produce, what do they give and what do they take away? And to whatever we do at the foundation and through our partners and with the government, I think that's becoming the cornerstone or the lens we're trying to use no matter what. We've referred to the ASHA workers and whether it's actually useful for them. We've referred to consent in different frameworks, whether it's the ABDM framework or not. Do we really understand how somebody is going to act? I was talking to one of the speakers that, what are they going to read? When we read, we've always heard this, please read the offer document carefully before investing. Have we ever read what is written above that? And we're expecting this to come in different languages. We're expecting this to be used for healthcare at the last mile, while an ASHA, who's a part of the community, or the A&M who's a part of the community, is actually delivering services, to actually read that aloud. I think the implications of some of these things are yet to be understood. How they are going to be rolled out is yet to be understood and actually developed. And I know the Ayushman Bharat Digital Mission is working on the consent artifact and the HIE, and I'm hoping some of these things come out of there. I think the second point I wanted to quickly make around what was said here as well was that there is a lot of data available, right? And there were questions around how do we start using standards. We talked a lot about standards today, but how do we really start using these standards? I think while ABDM framework was presented a couple of times, we did not touch upon the ABDM sandbox process. So if you get into the ABDM sandbox, right now there are about 600 active integrators in the process, and there is M1, M2, M3, and I can go into this at a separate, I can interact with you later. But once you get into this process, apart from it making sure that you can create, verify Abha, you can link Abha records, etc., it also enables you to start using the standards that Manisha had mentioned in the previous sessions as well. So you can make your products fire compliant. You can use SNOMED CT, etc. So if at all you have products available, I know there are industry folks here as well, I would urge you to just get into the sandbox process, and then the incentive policies, etc., that were mentioned earlier will also become something that you can leverage. I'll just pause here.
So Anisha, I think your talk was particularly interesting because when you talked about proportionate collection of data and the general principles we need to worry about and consider when we are building systems. As it is, research data or data in general is very poorly collected. What do you think, other than your general opinion about what happened today, what do you think is going to be the influence of these new acts in the process of, will people stop collecting data altogether? Are you going to then have a situation where data from places that cannot afford, say, an EPIC system or a standardized system, will they just get left out of the loop like Johnny was talking about today? Yeah. What are your thoughts?
No, absolutely. So I think when we look at regulations, especially because these regulations are being written right now, the goal is we have an incredible voice to be able to say what we want as, both as users and as practitioners as well as clinicians. We can tell what we want the regulation to do, right? Because we're in a weird position in history which very rarely happens in the legal space, where we're literally writing the laws that will guide what we will do with tech for the next couple of years, decades for the most part. So we have a lot of control in that system, and at least the way it's positioned right now, it's a citizen-centric system. We are advocating for the for the voiceless. When I say that, I really do mean that a lot of legislations, especially tech legislation, does look at it does not cater to the industry. I think the industry takes the heavy hand in the process. I think it probably is the person that's most violently regulated, most heavy-handedly regulated. We do keep in mind that, the ultimate person at the bottom is somebody who can't voice his opinion, somebody who might not be even able to give informed consent. So, when we were talking about, and Anaita was talking about informed consent, a lot of the times when, a regular, let's say a laborer is coming to a healthcare service provider to get access to healthcare, his last concern is, are you going to use my data for something else? That really isn't a concern of his, right? So even if we tell him, no, tomorrow this data might be leaked and you might have some adverse effects, it really does not bother him. And we can't be blind to those realities. So the way regulations are being written right now, they do keep the citizens in mind. It is written that way. The one thing that I would say is where there's a real lax and something that we can have a lot of influence in is the way regulator or the regulatory ship around health data is constructed. So if we look at the BFSI sector, of financial data is extremely well regulated, simply because in India, unless you have a very strong regulator, things don't happen. You don't follow regulations if you don't have a strong regulator. So BFSI is so heavily regulated, so because RBI and SEBI and everyone else in the ecosystem are such, strong-handed regulators. So I'm not saying that we need a heavy-handed regulator for good regulation, but I think as a starting off point, if equity is what we want, and polished equity that is breathing life into the regulation, then we should start with a strong-handed regulator. So I think that would be my take on it.
Thank you. And Dr. Uma, there's nothing more important than good data. Bad data leads to bad algorithms and bad outcomes. And you've championed this for years, and also you've also championed how to have good systems. So what are your take on today?
Yeah. So at the outset, I would like to say one thing, that today's deliberations, one is the content, like across the board, has been extremely good and very relevant. And also the fact that this is one of the rare occasions where we met all representatives of stakeholders, I think barring the patient. And some of us are patients at some point of the other time, so I think that's also represented. So therefore, it's a very relevant meeting. So, we can talk of AI, we can talk of digital health ecosystem, but there is no ecosystem without good data. So accurate data capture is very important. And I think we are now crossing that space from like where we were just doing data collection for the sake of data collection, because we've all spent a lot of time in just collecting data key, and we are all hoarders by nature, right? So we collect data and we hoard it and we don't use it, and then it loses relevance. So I think we have begun to ask the right questions, and then to provide answers for that, we are starting to collect relevant data. I think that's very important. What we must never lose focus of is that digital is not the be-all and end-all. It's just a tool to do things more efficiently. The data analysis that we've always been doing in our minds before. We used to write it on a piece of paper and we used to discuss it with each other. We used to analyze the data in our mind and arrive at a diagnosis and manage patients. We have now a better technology to do it. Like if my own brain can, just remember, okay, the last 30 patients that I've seen, now I have technology available where I can have that interpretation based on the data from like millions of patients. And I think therefore, collecting relevant data is very important, and also not to really, lose the big picture, that at no point we should compromise patient safety. And this whole discussion we had about data privacy and security, we must very clearly understand that it is contextual. Privacy and security are two absolutely different things. Data security, globally we can have a constant regulation and all that, but privacy is socially contextual. So I think we must not ape others in the way we decide laws regarding privacy in India, and also in India across different cultures. I think we have to really be very, very careful. So therefore, be very careful about the way we collect data, and be very, very, remember to not waste your resources in collecting unnecessary data.
Yeah, that's a really interesting point, the one about being contextual about how you look at privacy. For instance, when I visit a the UK, for instance, I am totally annoyed by the number of times I have to click OK at the bottom for each page. Not so much worried about what's happening at the point, because from the context that I come in, it's very different. But truly respecting people and their views is really something that's interesting. So I want to come back to this question about proportionate data collection. I know on the one hand we are hoarders of data, but I'm also a researcher, so I like data, but I like good quality data coming in. But with AI and new technologies that have been coming up, you really don't know what all data sets, the more types of clean data points that you have enable systems better. So in that context, how do you bring, when you're thinking and designing data to be collected, especially in routine care, what is proportionate data collection?
Can I start?
Yeah.
So proportionate to me would be that for whatever question is it that we want to answer, the relevant data for that should be collected. But I also understand your point of view that as a researcher, I need to have a lot of data because I don't know what are the answers that I will want to have in future, and we do want to have that data. I would say that, okay, if it is effortless for you, if you can automate correct data collection, go ahead and do it. But if it is causing you misery, I think refrain from it.
Fair enough. So if there are questions, if you could just send that across, and I think we have about 5-7 minutes. We will take questions if you send that into the WhatsApp. Just want to get back again from the context of research to Sanjay. What do you think are the challenges in India with collecting good quality data that would be useful for research from within data systems per se? What could we do better?
So I think one of the things that I think I refer to my sort of previous comment around, we've been running this cohort study for the last 2 decades in Telangana. And every few years we've done routine kind of medical grade data collection, research grade data collection with standardized methods. But this was a time where we went very heavy on collecting lots of digital data. And it wasn't just for the heck of it, because the hope there is that a lot of the data that we've been collecting through traditional manners could be turned into a lot less participant burden issue by going digital, voice samples, vision samples, all of those things. And potentially moving on to citizen science models where we've been trying to explore the idea that we can get the participants to collaborate with us in collecting their own data and sharing with us, and the quid pro quo being that we go back to them and educate them by co-analyzing the data together with them for their understanding. So I think one of the advantages for technology could be that we move on to, for example, collecting diet data. You can either ask a 200-item questionnaire, or you can get people to take images of their meals over 2 or 3 days, which we are doing now, and using that to analyze with AI to understand the calorie intake, for example. So those are some examples where technology actually could be a plus rather than a minus.
Right. Anaita, you have a lot of experience in UP and Bihar. For instance, when you want to build these models that are relevant to people there, it is also an equity issue, being able to have models that predict what's appropriate for people who live in Bharat, as Johnny would put it. What is your experience with that kind of data collection?
I think firstly, at least from a public health system perspective, just based on my experience, the fact that we are trying to now move a little away from administratively collecting data to make decisions to actually what's actually required for the end user is a very big change. I think with COVID, because there was a very clear need of what kind of data had to be collected to be able to get services delivered or vaccines delivered, we suddenly started thinking about the principle of data minimalism. At least in the UP construct, I can give an example where the frontline workers were trained on a new digital platform for the first time that had just been developed in the span of a month. Labs from the public-private sector came in. They were trying to, for a state like UP, they were trying to use an end-to-end case management tool to be able to drive better COVID management in the state. We know the cons of whatever happened, but I think from a digital perspective, when we were trying to train, the one feedback that they continuously gave us was, when we were trying to develop, design, etc., was please don't add too many data elements. These are the 5 things I have to collect, just restricted to that. So that's like the first thing, like the basic thing we are trying to move away from, where principle of data minimalism is used. What is actually useful for the end user is put up. Over and above that, slowly, as you start getting quality data, because if you don't just start from here, you're never going to get quality data. Then you're just forcing 50,000 fields to be filled in because we are hoarders. I'm sure there is advantage to be able to do research based on this once you've got anonymized data, etc. But if the base data is not correct, there's no point of collecting that. So I think those are some of those key principles we're trying to leverage to actually start developing much more confidence in the end users that this is a job aid for you. The data is actually useful for you, and then we're also going to build on it based on the data that you give us for research.
Right. So that brings us, we are hoarders of data and we collect a lot of data. So, and on the other hand, there is this new law and the 5 crore penalty that comes with it. So we know, looking at data being collected, and we also know that when we want to use this data, process data, there is, the opportunity of using the cloud, the infrastructure is much cheaper. But at the same time, you have to worry about security, cyber security. How do you deal with cyber security in this context? Do we use state-of-art systems? Then there is a cost to it. What are your thoughts on that?
I think whenever you deal with medical data, you have to be extremely careful with what you put out. Unfortunately, with the way the world is going, data is getting more and more distributed. You have data not just kept in the hospital on a standalone server, but it moves on to distributed systems, it moves on to the cloud, and therefore you have to follow best security practices. So how do you do that? When you develop your software systems, you need to follow standards, you need to follow best practices, and you need to constantly evaluate your security. Security is a state of mind. It's not a one-time process where you actually develop a product and then say it works fine, because you have vulnerabilities that keep coming in, new vulnerabilities that are discovered, and you need to keep evolving and adapting and modifying your product and constantly testing it to make sure that it is secure. So that is something that needs to be done.
Yep. So we need to be watchful. So there are some questions that have come up. I think I'll take one here. This is from Rohit. We all know that AI outperforms humans in most decision-making processes. His question is, can AI ever be a better teacher than humans? Anybody wants to try that?
I'll probably give a shot at that for radiology. So there are some tools for radiology that have come up. Some of them are even certified by FDA. But these are tools for very specific questions. So the human mind can analyze a diverse set of data points and come up with diverse answers. When you have an AI data set that is modeled or engineered, presently most data sets will look at very specific problems and come up with very specific answers. You give it something that is slightly out of its parameters and it will come out with garbage. So maybe in the future you will have more intelligence data sets, like for example with GPT-3 and GPT-4. GPT-4 actually gives you a lot more better output as compared to GPT-3, and it's an evolution. But it is still not perfect. You still have a lot of false data that comes out of it. So in the future, yes, maybe a few decades from now when computing power increases and when you get better data that comes into the system, you might get better research and a better output. But it's very unlikely that probably AI will replace the human mind in the near future.
That's reassuring. Uma?
Yeah, I think what I would say is that, whatever are the objective elements required in teaching, which are very standard, process-driven, that can be done through a system. But there are a lot of subjective elements in teaching, the interaction between the student and the teacher, and from your experience, how there are certain nuances that you cover during teaching. That none of the AI solutions will be able to do, at least that is what I feel. None of these solutions are going to replace a human mind. There are certain characteristics of human mind and human interaction that so AI will be a complementary tool to teaching. It will take away the mundane teaching that, we waste so much time over. I think those can be covered. That is what I feel.
So the next one's really for Anisha and for everybody else, but this is a question about how many data protection officers would an organization need, given how much of different data points come in?
Just one. You just need one data protection officer. Okay, this is my legal answer. You need one to get away with compliance. Nobody will come after you if you have one. If you have more than one, then fantastic job. You have the resources to hire more than one data protection officers. I'm sure there's a lot of healthcare service providers around the world who'll say, can you give us a little bit of your resourcing? So just one is required because on a different note, the reason why the data protection officer is a separate role apart from your IT manager or your CIO or a CTO is because his entire job profile is to just do data protection. Not cybersecurity, not IT management, not internal analytics, research head, nothing. His entire job is to make sure that the best principles or the best practices of the organization are compliant with regulations, are compliant with global standards, are compliant with principles. So that's the entire job profile. So we think it's a minimal enough job profile for one person to do it. But if you have a very large system, then probably you need more than one. But in terms of compliance, just one should be fine.
Should we have a frequent audit of our cybersecurity, and should there be a need for, like, should we prescribe something like that?
In fact, the new regulation, the Data Protection Bill, mandates internal audits. It's a mandatory requirement, so you have to conduct an internal audit and an external audit in a 6-month period, and you also have an additional data protection impact assessment. That's something that's just picking up in India now, something that the GDPR and HIPAA has been talking for a long time, but you also have to do a data protection impact assessment. So you have an internal auditor just doing data protection audits for you. Yeah.
So I think it brings us to one of the questions one of the participants had, is AI being used to satisfy human greed? And how should you define what tasks AI should be used for in healthcare? Is there something that's prescriptive, or is it that something which will evolve on its own? How do you see it? I mean, are there boundaries to what we should try and do? Maybe I'll get Raghu also onto this call at some point, but anyway.
I can answer this from a regulatory perspective, again, because that's my domain. There will never come a law that says prescriptively this is what AI can do in healthcare and AI can't do in healthcare, because that's never a decision that can be taken. But from a legislative perspective, we always think of the practitioner or the clinician as the ultimate decider. So there will never come a time in India, at least we believe, where an AI takes an independent decision on the care of a patient, ever. The clinician will always have a say in how ultimately things are mandated, how the care for an individual is prescribed. So there will never be a paternalistic prescriptive regulation. But if there's an internal best practice that allows, from an organizational perspective, if there's an internal best practice, then that might be something. But from a legislative perspective, that's never something that's going to happen.
So the real question is, where should AI go, and should people be using the, I mean, what kind of scenario do you think is not a no-go for us from a moral ground as well as from an entrepreneurial perspective?
Yeah, look, I'm not an ethicist. First, I should call that out, right? Generally, I think of AI, my perspective is I ask the question, where can AI improve outcomes, right? Or reduce, harm. That is usually my guiding principle. Now, we have a principle of do no harm, right? And I think that's a pretty good guiding principle. Often I have some difficulty with that do no harm, if often do no harm means do nothing, right? And this is something I really have a challenge with tertiary care doctors who say, oh, but then, this does not do that, do that. The place does not have basics, right? So sometimes maybe doing something little less perfect is better than doing nothing. And to me, that also falls in the do no harm bucket, right? So
it also brings in then the question of how is this whole process regulated, because somebody needs to watch out that it is not economic interest alone, and it is actually something that's permitted to do.
Look, this is a big beast, right? Folks such as this are trying to help the regulatory process along. The reason I am engaged with folks like ICMR is, for example, I was talking to SalSit folks earlier, right? Let's say philanthropist A or philanthropist B funds validation of a tool X that has claims Y, right? That's it. So you put all this effort, validated that tool once, created that data set, and you're done. And now tool A walks in and says, has similar claims. Are the philanthropists going to fund that again? So one of my motivations for doing the system we are doing is I want to try building a system which kind of evens out how we, and make it at the same time accessible, how we validate tools. QAI, I remember sitting down with Prashant back in 2018 and saying, hey, do you need help? He said, no, looks like we are making good progress. Fast forward 5 years later, is QAI deployed widely? They're still in current validations. But in the middle, they went and did a validation with Suvanand Sahu and Jacob Treswell in Stop TB partnership with BRAC over in Bangladesh, right? And this really, at some fundamental level, bothers me. We have the biggest TB burden, but do not have systems in a way that makes testing and validations. And the flip side of the same thing, right, when you talk about benchmark data sets, is the training bit, right? Folks probably in adjoining rooms at CMC Vellore don't share data, right? So I'm being very provocative here. So the reason we are building this system is the regulators, however, if I go to CDSCO, FDA does not build data sets. What do? They probably point to any number of NIH data sets that already exist that are somehow considered benchmark and say, tell us the results on this. Of course, you might bring your own data sets too, but that's like setting your own question paper, right? So I think we really need systems where we think horizontally and build systems where multiple folks can participate and have some sort of standardization of data. What does a benchmark data set for condition mean, et cetera? Sorry, long answer.
Thank you. We are going to have to close down, otherwise Joy is going to throw me out, and there's Balu telling me time's up, but a last point from Anaita.
2 points to just add to that. One, there is a cough for TB solution that Wadhwani Air had developed, and it's been in the works for a really long time. And just this morning, I got a circular that it's going to be tested across 130 plus Nagaland HWCs. So that's something that I assume, made some progress to be able to reach where we have. Of course, we were working on the anthropometry tool for years, and we're still to crack that. Having said that, the first speaker today had mentioned AI for processes and AI for outcomes, right? And I think for the AI for processes part, for example, on health insurance and the claims platform that's coming in, there can be very categorical SLAs getting developed around. If you turn this around, you have to have machine-readable formats. If you don't, you need to be able to scan all those not being able to read formats and pull them back. And if you process the claim in, say, X days, this is an incentive attached. If you process it in 2X days, it gets reduced. There are and similarly, when you're doing clinical decision support tools for things where we are sure that AI will be able to actually adjust this to what the preferences of that particular clinician are. Does not skip steps, does not try to become over smart or standardize it, because this is not something that we can mess around with. But those are the kind of things that we can slowly start thinking about. There's a long way to go in terms of actually using this, like was also said, regulatorily, to be able to drive better health outcomes.
So unfortunately, we run out of time, but there's been a very interesting discussion. Thanks to all the panelists. And if you have more questions for them, there is the dinner and the networking time as well. Thank you so much.